May I invite our President, Dr. Shamim, for the welcome speech.
Shall I start?
Yeah.
Am I audible?
Yeah, very much.
Yes,
A very good morning to all. Here it's a fine rainy day. Happy to see you all after a long time. So today we are very fortunate to have our endodontist, Dr. Narasimhan Bharadwaj, as a speaker for today's CDE on minimally invasive endodontics. So he'll be enlightening with us in the newest trends in endodontics. He is a Dentsply speaker, Dentsply Sirona, and I think he had been to our branch in 2015. I think it is the second time. So I, on behalf of IDA Kodungallur, welcome him to this webinar. And we know that MedPiper is providing us this platform with Zoom. So I welcome Snigdha ma'am to this meeting. I also welcome all the members who are present here for this Zoom webinar. And we have very few participants now. Hope they'll be joining soon. We are around, we have around 200 registrations, only 30 to 40 has joined now. Hope they'll be on the way. I hope we'll have a wonderful session today, and it will be very informative. I am sure of it. And actually, Dr. Baiju, our CD chairman, has planned a full day course on this topic. Due to the present pandemic, we could not do it. Quite unfortunate. So, hoping for a full session with lecture and hands-on once the pandemic is over. I request Dr. Baiju to introduce our speaker, Dr. Narasimhan Bharadwaj. Over to you, Dr. Baiju.
Thank you, Dr. Shamim. Good morning, all. It's my proud privilege to introduce our speaker today in the new platform this time. A passionate and prolific clinician, Dr. Narasimhan Bharadwaj is the founder director of Access Dental Institute, the Root Canal Center, established in 2001, a specialty-driven dental clinic with a microscope enhanced root canal treatment and training at Clifford, Chennai. The center is affiliated with the prestigious Mahsa University, Malaysia, to conduct and certify Fellowship Certificate in Endodontics, the FCE program. He is into clinical practice for the last 20 years and has presently carved a niche for himself in the field of microscopic endodontics globally. Being the first person in India to install and use the Calcis Extero 300 microscope in his practice, his field of interest include complex retreatment, instrument retrieval, etc. He holds 2 copyrights in original invention category, the Burrow platform technique for broken instrument retrieval, for which he was conferred the highest award for research in India, Fellow Indian Society for Dental Research, ISDR, and the second copyright for modifying the focusing technique using microscopes in dentistry, the reverse perfocaling technique. Presently designated as Professor, Department of Conservative and Endo at Savita Dental College, Chennai, he graduated his BDS and MDS from Dr. MGR Medical University. He was conferred the Best Outgoing Postgraduate Student Award in 2004 by the Federation of Operative Dentistry of India and Indian Endodontic Society. He is the founder faculty of EMFM, the Master Fellowship in Microendodontics, the first super specialty program in endodontics in India. Academically, he is an eminent speaker with over 400 plus invited guest lecture deliberations nationally and internationally with 6 original scientific best paper awards, and has authored many indexed publications to his credit. Further, he is the managing trustee of Community Dental Clinic, a charitable trust that is run primarily for the underprivileged with simultaneous clinical training for dentists. With these few highlights, I introduce our speaker, Dr. Narasimhan Bharadwaj. Over to you, sir. Welcome.
Thank you so much. Just share my screen. Are you able to see the screen?
Yes.
Yes, yes.
Doctor.
Is it full screen now?
Yeah.
Yes, doctor. Yeah.
Yeah. So first and foremost, I wish to thank IDA Kodungallur branch for giving me this wonderful opportunity for the second time, and the office bearers Shamim, Jitin, and Baiju sir for having me here amidst you all. And my very special mention to Dr. Plato Palathingal. I don't know whether he's here, who invited me in the year 2013 for this branch, and that is when I first came to your branch to see a bunch of very, very enthusiastic clinicians. So thank you, Baiju sir, Jitin, and Shamim sir for giving me this opportunity yet again. Looking forward to actually come and do it in person, because I'm not a guy who enjoys webinars, because I am a person who would like to interact much, but somehow I'm getting used to this thing because we don't have an option. So definitely I'm looking forward to come there as early as possible. And in fact, it was in March that I'm supposed to come there, and it got kind of rescheduled because of the pandemic. So first and foremost, I wish to thank the Almighty for giving us the power and courage to actually, to put it in simple words, survive amidst this pandemic. And also thank the Almighty because till today, we have not shut down. Our clinic has not closed even for one single day in the last 2 years. And that could not have happened because of without the power of the Almighty and all your best wishes. So we are still going on, and the comeback is always greater than the setback. I'm very sure about that. That dentistry is going to bounce back with flying colors once the pandemic is completely curtailed. And whatever I am, I owe to this great man. I wish to introduce him before I introduce myself, because what I am today, whatever designation sir has read me today, is all because of this great man who has carved me and presented to me before you today. So with this few words, I wish to go into today's topic, minimally invasive endodontics. Now, I strongly believe that any webinar or any online session could be to a maximum. In fact, when I was talking to Baiju sir the other day, when he said like 2 hours, I said, sir, 2 hours if we put, we'll have 80 participants, but if you mute them, we don't know where they are. So it doesn't happen that way. So maximum 45 minutes to 1 hour. So 1 hour is what I have time. After that, we'll have an interactive session, and then we will probably wind up. So today's topic is going to be minimally invasive endodontics. Now, what is that I'm going to be focusing in today's topic is very simple, clear, and straightforward. First, how do you do a minimally invasive access cavity, and what are the benefits? Most important, what are the benefits? Because today I see a lot of youngsters taking a lot of pride in putting photos in Facebook and WhatsApp, telling that a small access or a tiny access, does it really make sense, or is that anything to do with the outcome? I'll focus on that. So what is actually meant by minimal access, and how to do a minimal shaping, and most importantly, where to do a minimal shaping. So it is not that, again, I would like to focus when I'm coming to the topic that a lot of people take immense pride today in saying that I work only with the 4%, I don't believe in a 6%. So it is not like that. So certain canals, certain situations need a 6%. So basically, I'm going to be highlighting where exactly this minimal intervention will work, and where you will need a 4% and where you need a 6%. And what are the irrigation protocols? The most important thing in endodontic procedure is the irrigation protocols. And the last touch and go on my favorite topic, which is magnification. I will not be highlighting much on magnification because today's topic is not on magnification, but still probably a couple of minutes I'll just focus on magnification to tell you what you can do with magnification, which may not be possible with your naked eye. So this is going to be the crux of today's topic. So to begin with, first and foremost, conventional versus micro access. Now, when we talk about conventional access, all of us has been taught in college that when you do a conventional access, you will have to see all the canals in a single plane, which means when you just put your mouth mirror, whether it is a maxillary tooth or a mandibular tooth, when you see in one single plane, you should be able to see all the 3 canals. This is what we have been taught as an undergraduate student. Now, this has transformed into something like a minimal access, or use the word orifice guided access, which means you're still in a straight line. but it is not necessary that you need to see it in a single plane. So in simple words, if I put it across, if you see the X-ray, now what you're seeing here is a conventional axis, which means that if you draw a straight line from the canal to the orifice to the KO surface, you see that the lines are diverging. The lines are diverging. This is what we call it as a conventional axis. Whereas in today's terms, when we call it as an orifice guided axis, this means that the line is converging. Now, if you ask me a simple question, does this have a straight line axis? Yes, it does have a straight line axis, because if you see from the orifice, in relation to the orifice, it's a straight line. Similarly, in relation to this orifice, it's a straight line. So the transformation is such that you need not see all the canals in a single plane. You can orient your plane and see the canals, but at the same time, they should have a minimal amount of an axis so that there is a free inflow of your file, rotary file. So that is what we call it as a minimally invasive axis. So the advantage what you get in that is that 2 to 3 millimeters of peri-cervical dentine is kind of stabilized or is available. Now, if you ask me a simple question, I myself have started practicing this about 4 years back when I started with the microscope. I used to do such small accesses, and trust me, I never used to give a crown. I never used to give a crown. But I want to redo my statement, because the same cases which I have done with such a tiny axis without a crown are fracturing. So a lot of people, today's youngsters, they say that when you do a very minimal axis, you don't have to give a crown. No, I beg to differ. It does fracture. Only thing is, you need not give a full crown. You can just go for a tabletop or an overlay or a cusp capping. All that in lithium disilicate you can actually fabricate. Okay, I'm not going to be going into today's, this is not today's topic, but I'm just telling you that most important thing, you remember that you have to cap the cusp. You will have to cover both the cusp if you want to avoid fracture. So I want to make this very clear to today's youngsters that if you are riding on a concept that if I do a very, very small axis or a trough or a ninja axis or something like that, I don't need to give a crown, please rethink. See your own cases. You will see that your own cases come back to you in about 3 to 4 years down with a tooth fracture. So doesn't replace. So you need a definitive cuspal coverage. There's absolutely no second thoughts about that. Now, to do this minimal or micro axis, you need to have a size 1 Endo Access Bar. Okay, any equivalent, Dentsply is there, any other, all some third-party companies, a lot of companies have, but preferably you need to size number 1. A lot of people use a size number 2. Even the company people, they support and they sell size number 2. Size number 2 access opening will become slightly bigger. So you need to buy an Endo Access size number 1 bar. So I'm just showing you some of my cases, how it will look like. Now you can see that this molar, you can see that it's an access opening done, and you can see the access cavity. Okay, so this is done again with the size number 1. And most importantly, you will need ultrasonics. Most importantly, you will need ultrasonic, because when you do troughing, when you do a little bit of widening with the burr, it widens up. So you need to take advantage of the use of ultrasonics if you want to do a perfect small microscopic axis. Just showing you some more cases, which all are my own cases. You can see the access cavity. You can see the access cavity here. So all these are examples of how you can actually go the axis very, very tiny and go towards the orifice. Now I call this as orifice guided access. Now I want to present a small case, my own case. You can see here the very, very interesting case. This is basically a class 5, a pulpal exposure because of a cervical lesion, a class 5. Now just see the occlusion, absolutely spick and span. Absolutely spick and span. There is no evidence of any caries on the occlusion aspect. Now, if we have to do an endo, how do we do? We basically take a burr and open into the premolar, the occlusal surface, and go down, right? So I tried something different. I completely tried something different. I opened the access through the class 5. I opened the access through the class 5, exposed the canal, and that is my working length, that is my canal, and then I've completed my shaping. That is my shaping, which is completed. So it's all in eccentric like this through the class 5. And then at the end, what I did, I used my ultrasonic tips. Very important, because what is there on the top? The pulp chamber is there. In the pulp chamber, there will still be caries left behind. So you need to use your ultrasonic nicely. It will be like this. The kiss tip will be like this, like a claw. So you put it across inside and nicely trough it like that. So whatever pulp tissue is remaining in the pulp chamber comes out, and that is my master cone, and that is the post-op obturation. And this is how you do the entrance filling. You can see that the temporary filling is completely removed, and this is the completed case. Now, in this particular case, I don't give a crown. I don't give a crown. Now, why? You can ask me why. Most important thing, remember, the entire integrity of the tooth, or there is a concept called cuspal flexure, which means that when somebody bites, both the cusp flex like that. Now, which is the one which is preventing the cuspal flexure is the roof. Now, the simple logic in endodontics is, if the roof is intact, if the roof is intact, then you can avoid a crown. If you have perforated the roof, that is, in simple words, if you have done the access through the occlusal surface, obviously you're going to go through the roof. When you have done through the roof, definitely that tooth needs a cuspal coverage. This is what I have observed in my 20 years of clinical practice. So, if at all, if you don't want to give a crown, you can do it, provided you're not touching the roof. You're completely keeping the roof intact. But if you have opened through the roof, some people use a truss access. Yes, to a certain degree, if you have done a truss access, which means that the part of the roof will be intact, you can open mesial, you can open distal, and then restore. That also not much of clinical studies are available to showing the long-term effect. See, everything works in 1 year. Our intention is not 1 year. You should have at least a 4 to 5 year follow-up to show that anything which you're doing works. So if the roof is intact, then this particular case don't need a crown. This particular case don't need a crown, because the occlusal surface is absolutely intact. Now this is yet another access which I'm showing. All of my own cases, you see that this is a class 3 of an anterior. Class 3 of an anterior. This was actually referred to me. So what I did was, and that is, you can see that under rubber dam isolation, you can see that the class 3 of 1-1 and 2-1. So I opened the access through the class 3. Okay, keeping the entire palatal surface intact. Completely palatal surface was intact. I opened the access through the class 3, and that is the master cone. You can see that. And once I finished my master cone, and then I finished my obturation, and I referred it back. So that told that person, now in this particular case, you can just remove the temporary filling, go for a composite buildup, or go for a veneer, or whatever you feel like. So again, what is the advantage here? The entire stress bearing area, which is the cingulum. In an anterior tooth, you know that it's a cingulum. Cingulum is intact. So if the cingulum is intact, these teeth don't need a crown. And for anterior tooth, if the tooth structure is good, you don't need a crown. I hope you guys are there with me. You're able to follow? So this is basically a deviated access from the conventional, where I open the access through the class 3. So now we will go to the minimally invasive shaping concepts. So we'll go to the minimally invasive shaping concepts. Now here, first and foremost, very, very, very important. I keep listening, or I keep hearing a lot of people asking me this particular question, that which rotary system do I select, sir? Can I go for a 4-person system, or can I go for a 6-person system? Now, how do I go with my rotary system? Now, a lot of people say that, sir, unnecessarily we should not use a 6-person. We should not widen it. Some people say that, no, it is better to use a 6-person. So how do I select my rotary system? So as we all are aware, there are 2 broad categories of rotary systems available. One is the variable or the greater taper rotary systems, which basically highlights on the elimination of microbes, which means that you shape the canal well so that your irrigant reaches completely and removes all the microorganisms. This is what the greater taper concept focuses on. On the other side, you have the lesser taper concept, wherein they say that unnecessarily don't widen the tooth, or don't widen the tooth structure of the canal, so that you actually don't preserve the pericervical dentine and radical dentine. Don't widen, use a 4%. So as we all are aware, these 2 different broad groups of tapers of files are available with us. Now, which is the best? How to select? Now, let me put it in one word. both are mandatory, both are required. One cannot replace the other. I want to put it very simple words. One cannot replace the other. Now, which, when, and why? Now, when we talk about which, when, and why, one simple aspect which I would like to emphasize, or what I practice in my, or I do in my practice is, I do something called as apical gauging or apical patency with my size 10K file, which means once I open the access, I use my size 10 file and I go into the canal, gauge the canal, which means I see with my tactile sense whether the size 10 file is going with relative ease or very easily, or it is struggling, or it is highly struggling. So it can be one of the four, nothing else it can be. So if the size 10 is going to go freely, then you know that fine, you have a good working width. I'll talk about that. Now, when the size 10 is really struggling, which means that the canal is very thin. So this is called as the apical gauging. Now see this video. This is how you gauge. So do a watch winding movement and take the size 10 file, 2-fro watch winding, and take it and hit to the full length of the canal. Now, if this is happening, if you are able to take your size 10 file completely to reach the complete length, then this particular case reflects it has got a normal working width. This is what we call it as working width. We all know something called working length. Working length is from the surface to the apical foramen. That we all know. I'm not going to talk about that. Now, what is working width? If a size 10 file, if you're able to completely negotiate completely fully with ease and it goes inside, you're able to, then it means that you're working on a canal which has got a normal working width. I hope you guys understand. Okay. So now when a size 10 is struggling, whereas a size 10 is struggling, it could be a narrow canal like an MB2, it could be mandibular anteriors, lower centrals, it could be a calcified canal, it can have acute curvature. Now these are the cases where a size 10 file is going to really struggle so that you are not able to go inside. Now those cases are referred to as working width which is less. Okay, now these are cases where the working width is very less. Now in such cases, if the working width is less, one particular solution is, this is where your specialized files come into play, like your C+ files, your definders, etc. Whereas the tip is little stiff. So a lot of people ask me, sir, where do you use these C+ files? Are they useful? No, it is these places. When a conventional size 10K file is struggling, then you take advantage of these specialized files so that the tip will go with relative ease. Now, if it is going to be a normal working width, I repeat, if it is going to be a normal working width, any day I prefer a 6% taper. Any day I prefer to finish with a 6% taper. I'll tell you the reasons, scientific reasons I'll tell you. Whereas if I encounter a canal with the working width which is very less, or in simple words, it means it's a mesiobuccal 2, or a lower incisor, or a calcified, or a one with an acute curvature. In such cases, I will finish with a 4% taper. So, which would decide whether you want to go for a 4% or a 6% is, it does not depend upon whether I select this case, so I'll use a particular rotary system. No, it depends on canal to canal. There are so many instances where lower molar distal canal, I will finish with a 6% or a F1. Whereas the mesiobuccal, I'll still finish with a mesiobuccal, I'll go with a 4%. Mesiolingual, I'll finish with an F1. So like that, it depends on canal to canal. So wherever you feel that your working width is normal, prefer to obturate with a 6%. And wherever you feel that your working width is less, then you'll need a 4% taper. Now, orifice enhancement. This is again a concept which I completely accept and promote, because today again a lot of speakers, a lot of people say that I don't want to enlarge my orifice. Unnecessarily, I will not do orifice enlargement. I will straight away do my shaping. I beg to differ. Unless you enlarge your orifice, your stress on the instrument is going to be higher. So every chance of instrument separation is going to be there. So I completely believe in this concept of orifice enhancement, better because you have better visualization of the canal, reduces the coronal friction of the file, because you always remember the coronal one is the one that is actually catching. So it is better you open it so that the friction of the rotary file is much lesser. And most important, the coronal third of the canal acts as an irrigant reservoir. Now, when I'll talk about it, when I'm talking about the irrigation part, because as I think you must have heard from a lot of speakers in today's concept, that we don't use EDTA gels any longer, which means the RC help or the glides and all those things are no longer used, because it's been proved that those gels act as a nidus where the debris can get clogged into the dentine. So as a result of which you leave behind some organisms. So we don't use gels any longer unless and until we want it for your manual lubrication. Your sodium hypochlorite, when it is acting as a reservoir, will act like a lubricant. So if you want a little bit of sodium hypochlorite to be in the pulp chamber, you need to enlarge the coronal third of the canal so that it acts like a reservoir. Only then your instrument is going to go in with relative ease. So now, how do you select between the orifice shapers? If you have a normal working width, if you have a normal, I repeat, if you have a normal working width, a size 10 file is able to reach, then you go with your orifice opener, like your Protaper Gold SX, where it's basically a variously progressively taper. This you know, most of you know about this SX. Now, when you have, for example, a lesser working width, and this is where you will need an orifice modifier. So because you're going to finish with a 4%, remember, when you are going to finish with a 4%, or if you have a lesser working width, or in simple words, if your size 10 file is struggling, that is where you should use an orifice modifier. Don't use an orifice shaper because you'll be widening it. So as a result of which you will leave behind a lot of space after obturation. So where you will use an orifice modifier. So this is basically these are the geometry and the technical specifications of this. So any one, depending upon the working width, either you use an orifice modifier or you use an orifice shaper. Now, whether you're using an orifice modifier or an orifice shaper, or whether it is going to be normal working width or whether it is going to be lesser working width, or whatever be the canal, one step which is absolute mandatory is glide path. You need to have a good glide path. Now, according to this guy, John West, a glide path means a size 10 file should go in loose. It means it's a super loose number 10 endodontic file. Now, how do you get this super loose number 10 endodontic file? The easiest way is 15. So when you go for a 15, it goes inside, pre-curve if required, and then wash winding movement only. So automatically, when you go for a 15, your 10 becomes super loose. Now, this everyone knows. But what is the challenge? Now, what is the challenge? Now, most of you will accept with me that many times when the 10 is struggling, when the 10 is really struggling to enter inside, or in cases where it's a lesser working width, like a acute calcification or an acute curvature, or if it is going to be a lower central or MB2, if it is going to be like that, 10 will go inside comfortably well. Okay. Now, once the 10 reaches, for you to take the 15 over there, it becomes a real tough task. Because even though size 10 and size 15 are just adjacent numbers, you see that in cases, it can be too far. It can be too far. 10 will go inside, but 15 will be really struggling. Because the jump from 10 to 15 is extremely high. So it becomes too stiff. So in that cases, if you're going to continue with your 15, what will happen? There might be a chance that you might actually kind of ledge or elbow or transport it. Okay. And failure to pre-curve will result in straightening of the canal. So these two things can happen in many cases when you're jumping from a 10 to a 15 directly. So how do you offset this problem? In such cases, like lesser working with, how do you get the proper glide path? Now, it is in these cases that you need again a very specialized file which is called as a C pilot file. Now, here the best part of a C pilot file is if you see that it has a number called 12. It has a number called 12. So what happens is after the 10, instead of jumping directly to the 15, when the 15 is struggling, don't push it harder, because most of the times if you're going to push it harder, you ledge it. Okay, the most commonest cause of a ledge is a size 15. I don't know, I think you must have heard about this person called Dr. Mohammad Hamo, who is actually a very good clinician. If you listen to all his lectures, he'll say that My best friend is a size 10 and my enemy is a size 15, even though they both are good friends. Okay, so I always say that one file which is a villain, remember that one file which is a villain in the entire endodontics is size 15K file. You will have to be very, very, very cautious with the size 15K file. And for people who are beginners, this is something which has been taught very wrongly in college for you people. They always give you a pack of K files 15 to 40. And we always have the tendency, the moment you open the access, take a 15 size and put it inside. It is the biggest blunder you can commit in endodontics. I repeat, it is the biggest blunder you can commit in endodontics is start with a 15 size file. Never ever start with a villain. Never start with a 15 size file. So start with your 10. Once 10 reaches inside, then you know pretty well. Then your working length, then put 15. If 15 is struggling, don't. Go back to a 12 and then come to a 15. Then you will see that your 10 goes in freely. And then once this glide path is established, straight away you put any rotary file. Trust me, the rotary file will not break. So remember, if there is breakage of rotary file, don't blame the rotary file. Blame that you have not done the glide path properly. You have not done the glide path properly. Now you have certain mechanical glide path files after 10, which is like, Pro Glider, True Anatomy Glider. Okay, this is what we have, the latest one. It's very good, True Anatomy Glider. And of course, you have one more, which is called 1G. Not sure whether it's still available. I don't use it much because it's a 14% taper. Why I'm putting these three is these are the three glide path files that are available in India as far as international companies are concerned. Chinese companies, plenty are there. I don't believe and I don't use Chinese ones. So branded international companies, you have these three options to get a mechanical glide path done. Now, once you get the glide path, then the shaping of endodontics is a child's play. That's what Clifford Ruddell says. Whoever owns the glide path wins the shaping game of endodontics. And that is Clifford Ruddell. I was truly blessed to be personally trained by him in MedPiper, Switzerland. And this is when he visited India once to Delhi at the Asia Pacific Endodontic Congress, when we both actually had a session together. So now we will go with the rotary systems. Now, hybridize your own rotary. You have so much of rotary systems. Now, how do you select them? How do you kind of choose which canal? What do you choose them? Now, first and foremost, we all know that today we are moving in the direction of deformation files, which means heat-treated files. Okay, so gone are the days where you have shape memory files. Shape memory files are files where if you bend, it comes back to the original shape. That is the previous generation files. Nobody uses it now. Now the world is moving towards the deformation memory files, where when you bend the file and keep it, it stays in the bend position. So all the files which is used are heat-treated files. Now, when we talk about heat-treated files, okay, you must have read in the literature, but a lot of companies saying that, one company saying one name. Some company says like minus T wire, minus M wire, minus Z wire, minus this, minus that, minus this heat treatment, that heat treatment. Now understand something very, very simple. Very, very simple. It's like this. It's like what you see on the screen is nothing but egg. Okay. Now imagine egg to be the night eye. So what is all this? It's all various preparations of egg. That's all. Each one has got a different name. Everything has got a different name. But the fundamental crux is what? It's egg. So basically, remember that it's like this night eye. So what is common on the right side with so much of preparations? Two things is common. One is the raw material, which is egg. Second thing is heat. Heat is common. Now what is the variable? The time and temperature of the heat is the variable. So in simple words, every company takes night eye and heats them. Now what temperature they heat, what they get, at what temperature they cool down, how much time they heat will decide the different characteristic properties of every company of rotary system. So this is what every company does. So if you see here, you have various companies available. Okay, so everything is common, everything is night eye, everything is heat treated. Now it depends upon the type of the heat and temperature. Each one gives a little different characteristic property. That's how, like how when you bite a boiled egg or an omelette, each one has got a subtle difference in the taste. So like that in the consistency. So like that, subtly there is a difference. So now when we talk about, I'm going to be focusing on two files here. The Protaper Gold file. So basically, I don't want to go much into Protaper Gold because all of you know it. It's been there for ages. All of you are using it. Okay, just to show you the usage sequence, you know that this is S1. See how you can pre-curve it. You can actually pre-curve it, place it inside, and then you can start. Then you can start and see the strokes. The strokes is gentle inside with brushing, gentle inside with brushing. You can carefully observe how the file rotates. See how it goes inside, gentle inward movement and brushing on the wall. How I'm able to brush it on the wall. That is how you move a Protaper Gold file. That's how you move a Protaper Gold file. I'm just showing you a little bit of a close-up so you can appreciate how it goes inside and it kinds of goes along the walls. And you can see that the debris is clogged on the coronal third. You can see that the debris is clogged on the coronal third. So when you use an S1, it prepares the coronal third of the file. Coronal third of the canal. Now I use my next file, which is S2, and I pre-curve it, pre-bend it, so that I place it with ease into the canal, and then I take it inside, same way, you can see that. The first instance, I just wanted to show you, that is why I used it dry. Actually, you're supposed to use it in the presence of hypochlorite. You can see that the S2, the middle third of the file is kind of prepared. And then you have your F1. Always flood your chamber with hypochlorite. And then in the presence of hypo use. For S1, I just showed the video. Just for video's sake, I showed it dry so that you can appreciate the movement. You can see that in F1, again, it is there in the apical third, clogged in the apical third. So this is the usage sequence of S1, S2, and F1. So I don't want to go much into Protaper Gold because most of you know that. Okay. Now, when you have selective clinical situations, like you remember I told you about lesser working with, what are the situations? One is intentional RCT. If you're doing an intentional RCT, there is no need for you to enlarge. Supposing if you're doing it for a prosthodontic consideration, you have a slightly tilted tooth, you're scared that if you prep it and you might expose, in such situations, you don't have to enlarge at all. Directly you can go with the 4% and obturate, because I don't want any enlargement. Why? Because I don't want to remove any debris. The reason is there is no debris. It's a vital tooth. It's an intentional, it's an uninfected tooth. So intentional tooth. Initial apical file less than 10. This is what I was repeatedly telling you. Canals with lesser working width. MB2. Extremely long and curved canals. Thin root like mandibular roots. So these cases, as I told you, you need to go with a lesser tapered preparation, and the preferred one which I use is a true anatomy. Again, I'm telling you, a lot of files are available in the market, but my choice, I'm just giving you my choice. I shuffle between these two. I use my Protaper Gold and I use my true anatomy. And if it is going to be a straightforward canal with a normal working width, I go with my Gold. If it is a thinner canal with a lesser working width, I go with my true anatomy. So now what are the steps of true anatomy? The steps of true anatomy is, as we all know, first is orifice modifier. The next step is you have your glider. Now this is common. Up to glide path is common. And then you have one single file, which is basically the prime file to complete. Just a single file, one single file, a prime file to complete. So you finish it off. Now in case if the prime file is kind of struggling, it's kind of not going in with ease, then in that case, you can go with a small, which is a size 24%, and then come back to your prime, which is a 26.4% file. Okay, I repeat. So generally, orifice modifier, glide path file, and single file, which is a prime file. Now, in case if prime is struggling, then you go with a small and then come back to the prime. So that is how you complete. Okay, and there is also one more file called medium in the true anatomy. Very honestly, don't buy them, it's a waste. So I don't use them at all. So don't buy the assorted pack which has got all the ones. No, just buy only the orifice modifier, glide path, and the prime file, and maybe one or two small files you can use. You can keep. Medium is, I don't use medium because if it is a bigger canal, to use a medium, why will I go with the true anatomy? I'll have my Protaper Gold to go and complete the case. If it is a distal or a parietal, I wouldn't want to take a small file, do it, and then do a lot of lateral condensation. Why would I when I have a bigger taper file? Okay, so this is how I play with my system. So this is the sequence of the true anatomy. Now, one important thing, I'm just showing you some cases. These are some of the cases which I've done with true anatomy. You can see that it's a minimal access and then two canals where I've completed with 25% of a true anatomy. Now you can see that now here in the middle one, you can see distobuccal and palatal I've done with Protaper Gold, whereas mesiobuccal and MB2 thin canals I've completed with true anatomy. Similarly, here you can see that the mesiobuccal I've done with true anatomy, distobuccal and palatal I've done with the Protaper Gold. So this is how I shuffle with my system. So on the same tooth itself, I work with my size 10. If I feel it's a normal working width, I go with my gold. And if I feel it's a smaller, lesser working width, I go with my true anatomy. So minimum is size 25-4%. And one thing you will have to understand, in canals where you're using a true anatomy or a 25-4%, okay, you have to understand that the irrigant does not easily reach the apical third. Okay, irrigant does not easily reach the apical third because you have thin. So in such situation, the irrigant activation is mandatory and it has to be doubled, which means the time taken, like for instance, if I activate my distal canal where I'm finishing with my F1 for 30 seconds, I will activate my MB2 where I'm finishing with my 25-4% for 1 minute. So my irrigant activation will be doubled. Similarly, if I'm using 2 ml or 4 ml for distal canal, I'll use 8 ml for the mesiobuccal canal where I'm finishing with my 4% taper, because you have to understand that when you finish with the 4% taper, the irrigant part to reach the apical third is very, very challenging. And what is the another drawback of 4%? Flow of calcium hydroxide and bioceramic to the apical third is slightly difficult. Or in simple words, if I'm doing a retreatment or if I'm working on a tooth where there's going to be a periapical lesion, I make it a point, I work till my 6% taper, because I want free flow of irrigant, free flow of calcium hydroxide and free flow of bioceramic sealer. Okay, so this is how I choose between my rotary systems. Now quickly, I have presented this during the true anatomy launch, so I won't take much time in this. I'll probably be a quick. So when you're working on lateral canals, how do you use? As I told you, there is no substitute for sodium hypochlorite. I repeat, there is absolutely no substitute for sodium hypochlorite. So if anyone says I don't use sodium hypochlorite, I'll be too blunt to say that I'm sorry to tell you that you are not doing endodontics. You are not fit to do endodontics. Simple word. Okay, so there is no endodontics without sodium hypochlorite. It's absolutely mandatory. 3 or 5% use undiluted. If you ask my opinion, I prefer a 3% for a long duration and more volume. Lot of academicians, lot of very big speakers, they say that yes, all the research points of that 5% is good. Yes, I understand. I know that 5% is good, but how many of us, touch your heart and say, as clinicians, capable of securing a pakka rubber dam without even a drop of leakage to use a 5%? So it's not practical and clinical. Okay, so when you're using a rubber dam, it's always mandatory to use rubber dam. There's no, if in all my cases you see that I present only with rubber dam. But still, I know a lot of clinicians in a lot of places where they don't use rubber dam. We have to be logically practical. That is the reality and truth. So when you're not using a rubber dam, there's no option of a 5%. You can't use a 5% at all, because when you use a 5%, you're going to burn the gingiva. So there you need only a 3%, and 3% is going to act less. I understand, but how do you make the 3% act better? Increase the volume, increase the duration. That's how you do it. So the best way to do it is, this is again my own term. I use the term working solution. I use sodium hypochlorite as my working solution, which means that I always open the access, and whenever there's a class 2, I build it with my composite temporary wall. Okay, you can just have any flowable composite, cheap quality flowable composite, and build it up just for 45 minutes. Once you finish it, you can remove with your probe. So it's called as a temporary wall. So once you build the temporary wall, what is the advantage? You can confine the sodium hypochlorite in the bulk chamber. If you are able to confine the sodium hypochlorite in the bulk chamber, that acts like a working solution or an irrigant reservoir. Now saline becomes my flushing irrigant. It has no action. Then you have chlorhexidine gluconate, excellent antimicrobial properties. So used only as a final rinse. Now, and don't dilute chlorhexidine gluconate. A lot of people have this habit of diluting chlorhexidine gluconate, and lot of clinicians I've seen, they use chlorhexidine gluconate and they just keep rinsing it out. This is rinsing. You are wasting your time and money. There's no point in rinsing chlorhexidine gluconate as an irrigant. You have to use it only as a final rinse in cases with periapical lesion. If you're handling a vital tooth, why do you need chlorhexidine gluconate? You don't need chlorhexidine gluconate at all. And then you have EDTA as an irrigant to remove smear layer, as a chelating agent, as I told you, not much nowadays, and as a lubrication gel, also not much nowadays. So gone are the days of RC helps. I don't use RC helps at all. So directly use my sodium hypo in my pulp chamber. That acts like a lubricant, that acts like a working solution, and that acts like a irrigant reservoir. So all the three are got in that particular step. Now, whether sodium hypochlorite reaches the apical third. So you need to understand that when you talk about irrigation protocols, two steps are important. One is I need to take my sodium hypochlorite to the apical third. And second is I need to activate my sodium hypochlorite. So two important steps. One is I have to take it over there, and second is I have to activate it. Now, when you compare it to the stiff needle and a plastic flexible cannula, now what is the advantage? When we use the stiff needle, you see that the needle will go only till the point where the canal is straight. The moment the canal bends, or in the moment the canal takes a curvature, a straight stiff needle is not capable of taking that pathway. That is the biggest drawback of a needle. Whereas when you have a cannula, a plastic or a resin cannula, the advantage is you see that the cannula will be able to take the curvature of the canal and reach to the apical third. So this is the True Anatomy irrigation needle. This is just a magical needle. Trust me, people who have used it will fall in love with it. It's just a magical needle, a magical solution. 30 gauge, 4% taper, a soft plastic body, and absolutely no wedging. You don't have to bother about whether you're wedging it or not, whether you will be pushing it beyond the apex, because it's a plastic flexible cannula. It cannot wedge. It will be very passive inside the canal. And it's a transparent cannula. You can see whether the hypochlorite is moving or not. Okay. The length is 27 mm. It's millimeter marked again. So you know to how much depth your cannula is going. Suppose you know your working length is this much. If your cannula is going to reach 18, 19, you know that, okay, I'm there in the apical third. Whereas the needle, you don't know. You might be just there in the coronal third. Your irrigant may not reach even the apical third. Whereas here, you know precisely where you're actually placing your needle. And this is the lower lock, firmly secure. Any syringe will work. Not necessarily you'll have to buy a special syringe. Your normal 2 rupees Unilock syringe will work for it. Adaptable with all disposable syringe. It has double-sided vents. And just see this video, you'll understand how beautifully the cannula goes inside. It's a 4% prepared. The canal is 4% prepared. So see how beautifully the cannula is able to go almost till 2 millimeters short of the apical foramen, and then it's able to come out. Can you see that? How beautifully the cannula goes. Now this is impossible with a needle. If you're using a normal syringe, how can a syringe bend like this and go like this? It's not possible. It won't go. It will just go till the straight portion, it will stop. Whereas a cannula can just bend like that and it will go inside and reach the apical third. And then once you finish your delivery, the next comes your activation. Use either ultrasonic to activate it. This is your normal scaler. Use an endo tip on a scaler, put hypo and activate it. This is ultrasonic activation. Only thing is you need to be a bit cautious, because when you bind the ultrasonic tip, sometimes the tip breaks. So you need to be a bit cautious. And this is sonic activation. This is basically what I prefer and I use a lot, because again, same thing. The advantage here is it's a plastic. It's a flexible polymer. So you can take it inside to whatever direction. Whereas ultrasonic irrigation is stiff, stainless steel. So you cannot take it in a curved canal. Whereas here you can know that you can actually take it down inside into a curved canal and nicely you can activate it. So this is the advantage of using a sonic activation. So one is you take a flexible cannula to reach the apical third. Next is you activate either with sodium with ultrasonic or with sonic, okay, or laser. If you have a laser, if your clinic is blessed to have a laser, take advantage. This is what is so called as the laser root canal, where you put your hypochlorite inside, take the soft tissue laser and just laser it. Just go into the canal and warm it. Okay, so this is how you do your laser activation in the presence of sodium hypochlorite. And you can see that it's one of the best bactericidal action in the canal. So now, when you do a good irrigant activation, irrigant warming, and you're able to reach the irrigant to the apical third, and you use the right appropriate sealer, then you know that all this is possible. Now, whatever you see on the screen is my own cases. All are my own cases. You can see how beautifully lateral fills are taken in the first one. You can see the second one, lateral fill, that's called as a elephant trunk. The third one is the lateral canal. The fourth one, lateral canal. The fifth one, you can see there are almost 4 lateral canals. And the sixth one, you can see the lateral fills as well. All these are my own cases. So, and how are these got? It is not because of Protaper Gold or True Anatomy. It is because of the ability to reach the apical third with my cannula and do a good eye activation of my sodium hypochlorite and select the appropriate sealer. Now, a little bit of, perfect time, 57. 3 more minutes. So, I'll just touch and go on magnification. As we all know, magnification, you have loops and microscopes. I won't go much into microscopes now. I just want to focus a little bit on loops. Now remember, all dental procedures, you can use comfortably a loop. Definitely your thing will be enhanced. Microscope is the best, no doubts. But microscope involves a little bit of a learning curve. Okay, a little bit of a learning curve. And for people who are into hardcore general practice, if you are seeing about say 20-25 patients in a day, for you to adapt to microscope might be a little difficult in the initial stages because it takes a little bit of time. Whereas with a loop, you can just easily transform. So I always say, a lot of people differ with me. They say like, loop cannot be a microscope. Yes, loop cannot be a microscope. But when you want to transform, the best thing is first start to learn a cycle. When you're able to ride a cycle comfortably, then driving a bike becomes easier. So it's like loop is nothing but a cycle. It's like in between. So from a normal practice, shift over to a loop. When you shift over to a loop, you know precisely that you are in the next platform. Once you're comfortable with the loop, once you're able to orient, focus, magnify and see, then it's easy for you to adapt to a microscope. And for endo, most of the MB2s, extra canals, calcification, repairs, all these can be performed with a loop. And resto, trust me, if you're doing your finish lines and crowns, you should see the finish line with a loop, and then you remove your loop and see the finish line. You will be wondering, my God, did I do this crown for so many years? That's the feeling that you will get. Okay. So in surgery, fractured root stump removal, implant countersinking, etc., etc. So virtually, in my opinion, if you ask me, I would say the first thing to upgrade in your clinic should be to get a good magnifying loop. When you get a good magnifying loop, you will go to the next platform. Then from there, shifting over to a microscope becomes a little bit more easier. So then you shift over to a microscope, and this is how I work now. This is my microscopic practice. I work on a Carl's eyes. Here, this is the place where I work. And of course, just to show my favorite ones, my instrument retrieval, where I've actually done a lot of research work, and I've got my copyright. This is my retrieval technique. You can see there, most of the cases are referred. You can see that how there are 2 instruments, and I'm able to retrieve it without altering the anatomy of the root. So the crux of my copyright, the crux of my research is not retrieval. It is how well you are able to retrieve without altering the original anatomy of the root. That's the most important, because I see a lot of today's youngsters, they retrieve it, and at the end of the day, if you see the root, there's no root, hardly any root left behind. They trust so much. And what is the point? It's like surgery successful, patient dead. What is the point in retrieving the instrument when you have removed so much of root there? So what is my copyright is how to retrieve it with minimal amount of anatomical damage. So you see, I want you to see all my X-rays. Don't appreciate the retrieval. Appreciate the anatomy of the root, how well it is maintained after the retrieval. You can see that. It's actually periapical surgery. I retrieved. See the amount of opening. See the amount of the opening. It is just 1 millimeter. And with the 1 millimeter magnified, I will be able to retrieve the instrument. And this is my anatomy completely maintained. So this is my copyright. So this is my copyright is based on a platform technique, a very specially modified platform technique, which is used to retrieve the instrument with minimal damage to the root canal anatomy. And for this is the reason for which I was actually conferred the ISDR in the year 2019. And this is my second copyright, how to modify the focusing technique of microscopes, because most of the people, I don't know how many of you there are have started even using microscopes, but when you start using a microscope, the first thing which a lot of people tell is, sir, I'm not able to focus. I'm finding it very difficult. I'm taking a long time to actually focus. That's because the focusing technique which has been taught to us is wrong. What is there in the textbook, with due respects and regards, is absolutely wrong. Because what is there in the book is what is there for medical people. Now, what is, you can ask me, sir, what is the big difference? There is a huge difference between medical people using microscopes and dentals using microscopes. What is the big difference? Medical people are using microscopes in the operation theater where the subject is static. Whereas dentists are using microscopes in the dental chair where the subject is dynamic. It is like taking a photograph where the subject is static, and it is like taking a photograph during a car race. It's completely different. So when you're working on a microscope for dentists, you're working on a dynamic subject. So the focusing technique cannot be the same for what is being taught to us. This is my second copyright, which I've gotten for the reverse sparfocaling technique. So, yeah, exactly 1 hour. So the take-home message for today's lecture is that orifice guided access, use a size 1 burr, apical gauging to select your rotary file. Always gauge the canal with a size 10 file to know whether the canal belongs to a normal working width or a enhanced or a decreased working width. And then based on that, you select whether you need a greater taper or a lesser taper, and your armamentarium should have both. So which are the files, which rotary file should you use? Definitely you should have one greater taper system and one lesser taper system. Or in simple words, one 6% and one 4% should be present. Clinical guide, as I told you, for 4 and 6, which cases to use 4, which cases to use 6. And then irrigation protocols for a 4% has to be doubled. When you're finishing with the 4% taper, remember your irrigation has to be double. And then comes your magnification. Okay, so this is the take-home message for today. And this is my academy since 2012. 35 batches we have finished. Now we have a 36th batch actually scheduled in this month. This is a short-term course which we run in our training center. And this is the microscopic module that I do. This is probably the first center in India to have 7 various brands of microscopes, where we have train you with loops and microscopes for 2 days. And then this is the super specialty program that we run along with Savita Dental College. We have an MOU with Savita where we do the fellowship certificate, the master's fellowship in microendodontics program. This is run in Savita. And then we have a tie-up with the Masa University of Malaysia, where we actually do clinical modules, and we, after examination, we certify the FCE or the fellowship certificate in endodontics affiliated with the Masa University. And this is the day when I really felt truly blessed, when my professor, when my guru, who has made me, came to my center and asked me that, can I learn endodontics? Can I learn microscope with you? So I truly felt blessed the day I just fell into his feet. And more than I'm feeling best, his age is 80. Imagine at 80 years, a professor who has finished practicing has the zeal to learn something new in microscopes. Salute. So this is my endo line. This is my family, which I exist. And lastly, I wish to once again thank IDA Kodungallur branch for giving me this wonderful opportunity, and team Densply and Sumesh for coordinating this event. And thank you, the office bearers of IDA Kodungallur, for this wonderful opportunity. Thank you.
Thank you, sir, for a wonderful presentation. It was very much informative. We have few questions.
Yes, sir.
So the first one is, how can we save the roof in case of molar access?
Yeah, it is difficult. It is not possible. It is not possible to save the roof in case of molar access. Probably you can try to do a truss access. Truss access is partial saving of roof. The roof will be intact in between. The mesial and the distal will be open, and then you can do that. Whereas with the molar, definitely it is not possible. You will have to go for a cuspal coverage once you finish your root canal.
And next one is, how do you manage and tackle different anatomies, especially deep splits?
Definitely you need a microscope. No doubts about that, or at least a loop. Otherwise, it is not possible with your naked eye. Because with your naked eye, you can see only 2 millimeters into the coronal third. Beyond that, you won't be able to see. So if you have a split which is above 2 mm beyond the middle third, it is not possible. In my microscopic lecture itself, I would have showed you a lot of cases, if they have seen deep splits, where we go almost 7 mm into the canal and then it splits. And that's how you work. Without magnification, it is not possible.
So you don't use EDTA in calcified canals too?
No, I don't use. I use EDTA irrigant as an irrigant, 17% EDTA as an irrigant, but in calcified canals, I don't use EDTA gel. I mean, whoever has asked that question, even as a PG, as a student, we all got accustomed to that answer, that we all think that when you take the EDTA RC help, put it in the pulp chamber and put a closed dressing. Next day morning, you call the patient, you think that the canals are open. It only opens in theory, it doesn't open in practice. Nothing of that sort happens. So let me tell you, EDTA concept to soften dentine happens only when you open the orifice. EDTA does not help you in identifying the orifice and opening the orifice.
Next one is, would you recommend obturation with variable taper GP?
Yes, definitely yes. Whether you are obturating with variable taper or a static taper GT, it is not the gutta percha which determines the good seal. It is the sealer which determines the good seal. Okay, so if you are using zinc oxide eugenol, you definitely have to do either a warm vertical compaction or a lateral compaction, any one. Okay, but if you are using a bioceramic sealer, then the gutta percha does not play a role at all. You can even use a 6% taper preparation, use bioceramic sealer, even put a 4% GP, nothing will happen. Because the GP has no role to play in a bioceramic sealer. Whereas in a zinc oxidation sealer, gutta percha is the main. So the obturation completely depends upon the choice of your sealer.
Then what is your opinion about twin clean?
It's very good. I use twin clean. It's basically, that's why I think I mentioned it. I use EDTA liquid along with sodium hypochlorite. It's nothing but a freeze-dried EDTA powder where you mix it with sodium hypochlorite and use it. I use it. It's very good.
Then why EDTA gel like RC help shouldn't be used, sir? What are the disadvantages associated with?
Okay, there is you can actually go through articles, but still I'll just brief it to you. What happens is when you use EDTA gel and when you do shaping, what happens is as the rotary file rotates along the gel and goes into the canal, whatever debris is being pulled in outside pulled outside, get entangles in the gel, and the gel in turn pushes the GP into the radicular dentine. So what happens is the debris cleaning is not efficient. So that is the reason why EDTA gels are not being advocated now. The main role of EDTA gel is the lubricant property. Your sodium hypochlorite, if it is present in the canal, when your file is going inside, gives you the same amount of lubrication.
Sir, could you please suggest a good satellite compatible ultrasonic tip for irrigation activation?
Irisafe. IRRISAFE. Irisafe. It's basically a tip which is manufactured by Satellite, compatible with Satellite scaler.
And nowadays, because of using the face shield, I can't wear my loops. Any suggestions, sir?
No, you can, doctor. That I use my loop and my face shield. Can I just show you a picture? 1 minute. I'll just share the screen and show you a picture, like how you can use your face shield along with the loop. Give me a moment. I'll show you that picture. Can I share my screen? Yeah. Yeah, I'll just share my screen so that you can have a look. Oh, one second, doctor. Yeah. Yeah. Not able to bring it. I'll just paste it in this and show you. I'll just paste it in my first slide and I'll show you. Yeah. I'll just share my screen. Yeah. Can you see that?
Yes.
Yeah. Can you see that?
Yes, yes.
Okay. So this is how I work. So I can use my complete loop inside, and I do not know whether the brand is available in Kerala. I think it must be there. Studs is a brand.
Studs is available.
Studs is the brand. So you have this particular face shield where it complete is like an egg, like an egg. It comes like this, where you can use it. Very much you can use it.
No, sir. Can we sterilize and reuse this irrigation cannula?
Scientifically, no. Clinically, yes.
Cold sterilization or autoclave?
Cold sterilization, autoclave you can't do, sir, because autoclave, if you do it, it kind of softens, so you will not have that stiff thing. Again, see, it's just a clinical. To be very frank, it's like asking a question: can I reuse my rotary files? Scientifically, no, but Indian clinically, yes. All of us reuse rotary files. There is nobody in the world, to my knowledge, where they'll use a Protaper gold or anything and throw it in the dustbin. It's not possible. So basically, you need to reuse, but depends on the case. Like what case? If you're going to work on a very tough case, if you're working on an abscess case, don't use it on a vital tooth because you might transport the organisms. Same way, if the cannula, if you're using it on a non-vital or on a tooth which has got a very bad abscess, probably don't use it on a vital tooth because you might transport the organisms.
Then can you suggest me a good endo loop to begin with, sir?
2.5x is the best loop to start with as a beginner. There are about 3 or 4 loops available in India. Of course, I use only Carl Zeiss. Zeiss is the best. Next to Zeiss, you have Keeler. There's a brand called KWLER, Keeler, and the brand called Admatec, and a brand called Stack, STAC. These are some of the brands that are available in India, very much available in the Indian market. Of course, if you don't want to compromise, the best is Carl Zeiss. It's a one-time investment. You will not regret. You will start enjoying the loop.
No. Why gate glue and drills are not preferred recently?
For the simple reason because gauge skeleton drills does not maintain the canal anatomy. Because when we actually go into the gauge skeleton, they are not flexible. So they just go down and they completely enlarge it to almost 8% taper, which is not required. Whereas when you use your orifice shaper, it's a gradual enlargement. As I was telling you, if it is going to be a normal width, then you can go with the SX, which is going to enlarge about 6% to 1/2 the SX. Whereas if it is going to be a smaller one, you can go with your orifice modifier. So it will be a gradual enlargement. Whereas gauge skeleton drill will be a sudden enlargement and then it will be a decrease one.
Then can we use continuous chelation irrigant like chloroquine instead of sodium hypochlorite?
I am not too sure because I have not used them. I mean, to be very frank, I'm not too sure.
Sir, can you suggest good company to purchase loops, especially? You already
I
answered.
just told that.
Especially TTL loop is
TTL, the best to my knowledge in India is Admetec. Admetec is the best. I have an Admetec with me because I use it when I carry it outside. For the simple reason because it's very, very feather light. So I carry it in my laptop bag so that whenever I go for my courses, I start using them. But also, people who are asking about loops and people who are using loops, remember this also, it is a positive addiction. Like for example, now I'm coming to your center. If you casually show me a case, I won't be able to see. I don't have such a bad eyesight, but I won't be able to see even a clinical case without a loop because your eye is something called visual acuity. Your eye is accustomed to that particular size. It's like Cristiano Ronaldo cannot see a cricket ball all that easily because his eye is accustomed to that football. So like that. So when you're kind of accustomed to that particular size, okay, the 2.5x or a 3x, then when you see a teeth, naturally you'll be wondering where's the tooth. So always remember it's also a positive addiction. But of course you will enjoy the addiction.
Is manual dynamic agitation any good?
It is okay. Only thing is you have to be a bit cautious because it depends upon how well the guttapercha is fitting in. Because manual dynamic agitation is used with GP. So when you use a guttapercha and when you do up and down movement, if the guttapercha is snugly fitting in the apical third, there might be extrusion of sodium hypochlorite, which may cause a little bit of discomfort to the patient. That's why I don't prefer manual dynamic agitation because all these agitation systems like ultrasonic and sonic agitate the liquid on the sideways, whereas manual dynamic agitation agitates by vertical push and pull. That is the drawback.
Sir, your comments on apical tuning.
Comments on?
Apical tuning.
Apical tuning. I think apical gauging is what they are answering. I mean, I've not heard of the word called apical tuning. Can you just ask that person to kind of like, detail it? Maybe what do you mean by apical?
Only he'll be.
Apical gauging is basically to identify the size of the apical foramen approximately. That's why I told you the best way to apically gauge is to use a size 10 file. So I use a size 10 file and I know that if the size 10 file is kind of going in, I know that that is a case where I have a normal working width. Whereas when my size 10 is really struggling, and that is when I know that the working width is lesser, and that's when I'll resort to 4% tapered files.
Then what about PAX?
What about?
PAX, PAX.
Paxes? Can that person explain, please?
Dr. Ruxana, can you please unmute and ask?
Yeah. I'll be happy if I don't know also to learn something new.
We will go to the next question.
Okay.
What is your method of instrument retrieval?
Yeah. The method of instrument retrieval is if you actually, number one, you use a microscope. Goes without saying. Number two, use an ultrasonic. Now what happens is, according to the scientific literature, which has been published all these years, they do something called as a staging platform, which means they use a modified gauge, create a platform inside the canal, and then go along the platform and retrieve. This is how it's been done for ages. But what happens in this particular technique is, the platform is created irrespective of the size and shape of the anatomy. That is what I was not very comfortable with that. That is the one that was actually I was against it. And that is how I created a technique called burrow platform or the partial platform technique, which means I don't create a full platform. I just create a partial or a half platform around the file, along the course of the file in the innerward direction using an ultrasonic. In the staging platform technique, it is used using a modified gates, whereas in my technique, I use it using a ultrasonic. So I use that partial platform, and then using the partial platform, I go inside and then retrieve it. That is the modified burrow platform technique. Of course, you will be able to understand it if you see it much more in detail as a visual under the microscope using the videos. You will be able to understand it.
Sir, this is can I talk?
Yes, Dr. Rukshana.
Yes. Yeah. Sir, this is invented by Dr. Mandar Pimprekar, the same person who invented Twin Clean.
Doctor, that's called PATS. That's called PATS, not PACS. PATS.
Oh, I'm so sorry.
It's called PATS. Okay. Pressure assisted ultrasonic system. Okay, which means it's basically called air sonic. In simple word, it's called air sonic. You have an aerotor. You have an aerotor, right?
Yeah.
Same way, you have an aerotor handpiece into which instead of putting a burr, you will putting a plastic cannula and you will agitate it. Yes, it's good. It's good. I've used it. In fact, I have it in my training center also. I've used it. It's good. You can use. It's called PATS.
PATS. Okay. Thank you, sir.
Sir, next question is minimum canal preparation for calcium hydroxide placement in curved canals and straight canal.
Minimum canal preparation for a calcium hydroxide to be placed is 6%, whether it's a straight canal or a curved canal. But again, if it is going to be an MB2 where there is going to be acute curvature, preparing it to a 6% will be a slight challenge. In that cases, you have to use a calcium hydroxide using a lentulospiral. You know what is a lentulospiral, right? A paste carrier in a micromotor, so that you slightly push it into the canal and it goes into the 4%. If it is a 6%, it will easily go. If it is a 4%, it won't easily go. If you are able to prepare it to a 6%, nothing like it. But as I told you, if the canal is too curved and too narrow, and you might risk of breaking the file if you're preparing it to a 6%. In that case, if you're preparing to a 4%, your calcium hydroxide has to be placed only by using a lentulospiral. Manually, by pushing the calcium hydroxide, it will not go inside.
Sir, why can't we use medicated GPs as intracanal medicament?
Medicated GPs as intracanal medicaments is yet to see the light of the day, doctor, because even though they say medicated, we do not know the amount of medications that are released from the Gatapacha. Because if you are going to put it in a very high way, where the too much of medicines are released from the Gatapacha, the core, Gatapacha core will become weak. So as a result of which, any core will not have the capacity to release more of medicines, because anything which releases more by itself will become weak. So you don't want the medicines to release more, at the same time Gatapacha to become weak. That is why Gatapacha medicated is not yet to see the light of the day. Even though a lot of things are there, it's still in the research stage. It's like, for example, when you use glass ionomer, you know that the glass ionomer is a relatively less strength material because it releases a lot of fluoride. Now, when you increase the fluoride release, what happens? The strength of the material decreases. When you increase the strength, the fluoride releases decreases. That's why composite, that is why resin modified glass ionomer cement does not release much fluoride, because the strength is increased, the fluoride release will be decreased. So always remember, the release of any materials and the strength are inversely proportional.
Okay, sir. Sir, I want details of your course.
It's there in the website, doctor. www. It's there. If you want, I'll just put it once again.
Yeah.
Maybe I'll share it with Dr. Baiju. Sir, I'll put it in the group.
How can we get to know if the cleaning and shaping is well done?
If the cleaning and shaping is well done.
Yeah.
Clinically, you can probably see it. That's all. The maximum, you can't do it much. The best way to learn is post-operative symptoms. Now remember, if a patient is coming with less pain, I repeat, if the patient is coming with less pain And after the procedure, if the pain has become more, be it whatever procedure, be it the first sitting of RC or the second sitting of RC or the third sitting of RC, after the procedure if the pain has become more, it is a direct correlation that your irrigation is not sufficient. One line answer. It's a direct correlation that your irrigation is not sufficient, which means a lot of debris are left behind. Nowhere else the pain will become more. It's not like what we talk to the patient, your infection is more, that's why your pain is more. Never it happens. Remember, the patient comes with 50% of pain, and if after the procedure the pain has become 75%, it is because of you. It is because we have not used the irrigation properly. So that is the best way to correlate is post-operatively to check whether how is the patient is feeling. If the patient has more pain, next time make sure my irrigation protocol has to be more. I'll have to use more volume of irrigants.
Sir, what burr to use for the orifice enlargement?
Burr. Orifice enlargement is not done with the burr. Orifice enlargement is done only with your file. It's either an orifice shaper of Essex or an orifice modifier with true anatomy.
Now, when do you use post in endodontics?
That's another 45-minute lecture, doctor. Anyway, if I'll just put it in very simple word, for a posterior teeth, if more than one wall is missing, for an anterior teeth, if more than half the amount of clinical tooth structure is missing, then you can go for a post.
Sir, tell me about orifice modifier brand name.
True anatomy.
How can we get a proper dense obturation with the lateral compaction?
You can get a good amount of lateral compaction. You can good. Depends on again the sealer selection what you get. If you are working on a vital tooth, you can still use. You can use your resin sealer. If you're working on a non-vital, also you can use a resin sealer. Where resin sealers are contraindicated is when you have a periapical lesion. If you have a periapical lesion, a big lesion, don't use a resin sealer because inadvertently, if you push the sealer into the periapex, the sealer doesn't resorb, causing pain. That's when you don't use a resin sealer.
Now, can you suggest good economical biosealer, please?
Bioceramic sealer, CeraSeal, that's what I use. It's very good, quite economical as well. It is from the same company which produces Metapex. Meta. You must have seen that Metapex, what you use for pedo and all. No, the same company which produces that. It's called CeraSeal. And the best part is, it's the easiest to use because it has the same, imagine like Metapex is as a nice cannula where you just adapt it to the cannula and straightly inject it into the canal and then you finish it and put a GP. That's the easiest.
Then can we attach endo scaler tip to cheaper scalers like woodpecker?
You can attach, but again, it depends upon if you're using it for irrigation, yes, you can attach. But if you're using it for troughing or instrument retrieval, you cannot do. Why? Because when you're imparting pressure on the dentine, what happens is the amount of vibrations per second will vary from the scaler to the scaler, that is from the body of the scaler. If you're just using for ultrasonic, for irrigation purpose, it doesn't make a difference because you're only activating the sodium hypochlorite, which is a liquid. But if you're going to be troughing on the dentine to identify the MB2 or to enlarge the canal or to use instrument retrieval, then it doesn't work.
No, sir, irrigation with laser be used in curved canals?
Yes, you can use it. Again, the efficiency of the laser beyond the curvature will be a question mark. See, when you use a laser, there are twofold effect. One is direct beam exposure, direct light exposure. Second is by heating the sodium hypochlorite. The second will work because you're heating the sodium hypochlorite. The first will not work efficiently if it is going to be a curve. Till the point of curvature, both will work.
Then usually what is the amount of time that you take to finish one molar single sitting RCT?
There's nothing like that. There's nothing like that. There's nothing. I take sometimes even 2 sittings to finish. In fact, earlier when I was not using microscopes and loops, the time was much lesser. Once I started using loops and microscope, the time is much longer. Why? Because Now I identified MB2 is almost all the canals. I get a middle mesial. I start troughing. I'm able to see debris much more. I'm able to see the pulpal remnants more. So the more you see, the more time it takes. Actually, it's like as you master certain things, no, the time will be slightly longer. So now I don't do much single visit at all unless and until it's intentional, or probably I have to. Otherwise, I prefer to do it in 2 sittings because I know that for sure I won't be able to finish doing all the steps.
Can we do composite direct cusp capping if a small access opening, or it should be indirect ceramic only?
I would prefer an indirect ceramic because when you do a composite cusp capping, what happens is again, there is some degree of polymerization shrinkage which is happening with the composite. Now with the cuspal flexure, with the polymerization shrinkage, there is bound to be some degree of debonding which happens along the tooth composite interface, which might lead to a micro leakage. And if it leads to a micro leakage, it's actually very dangerous. Why? Because the patient will not know. It's RC treated teeth. The patient will come to you in only a catastrophic stage where there is no tooth is left behind, because there won't be any pain. Absolutely no pain. Because if it is a vital tooth, the moment there is micro leakage and the sensitivity is there, patient is going to report back to you. Whereas an RC treated teeth patient will not come to you till the tooth is almost damaged. That's why I prefer a indirect cusp capping. It's actually very minimal. You just do a very minimal preparation. Okay, it's probably another lecture. On the top, I give this lecture to GC actually. On the top, you just do a very minimal preparation and then take an impression and go for lithium disilicate overlays and then bond it. Only thing is you cannot cement it. You can't use a type 1 GIC. You will have to bond it like how you're bonding a veneer.
How do we make sure that the calcium hydroxide is well placed in the canal?
Lentillospiral. The best method is to use a paste carrier or a lentillospiral.
Sir, protocol for passive and active ultrasonic activation.
I told you, I showed a video also. One is ultrasonic irrigation is when you put a hypochlorite in the pulp chamber, use your ultrasonic tip. There is no active. Whoever's asked this question, remember there is no active. It's only passive ultrasonic irrigation. Okay, there's nothing called active, because if it is active, the tip will break. The moment the tip binds the canal, it will break. So the tip has to be passively placed into the coronal third of the canal without any binding. Okay, and then gentle irrigation, just activation for about 30 seconds per canal. When you activate it for 30 seconds per canal, there are 2 things that happen. One is acoustic streaming and cavitation. You see, which means it's like bubbling effect. You see bubbles coming out like that. As you see bubbles coming out like that, then you know that the ultrasonic activation is active. So please ensure don't bind the ultrasonic tip onto the canal. Very, very, very important. Whether you're using woodpecker or anything, okay, the tip will be like a very thin stainless steel tip. A lot of people make this mistake. They bind it. The moment you bind it, it will break. It's supposed to be loose.
Now, how difficult is it to retreat calcium silicate based sealer obturations?
Calcium silicate based bioceramic. Okay, it is very, 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 very simple, provided you have placed a gutta percha in the center. Now, all bioceramic or calcium silicate material sealers, you are supposed to obturate with single cone obturation. Now, if you take the literature, actually the single cone is not required. Like how you inject Metapex into a pedo pulp, similarly you can just inject Cerasil and leave it. It's good enough. But what happens is, in due course, supposing if it needs a retreatment or a post placement, you won't be able to remove the bioceramic sealer. That is the reason why you place one single gutta percha in the center, so that tomorrow if you have to retreat, you can enter through the gutta percha and remove the sealer. It's possible, very much possible, provided you have kept one gutta percha inside.
Now, how frequently we need to replace calcium hydroxide chlorhexidine paste in an infected case?
I generally use it only once. I just put it once and wait for about 1 week to 2 weeks, 7 to 14 days. And I see the lesion. That is, I see the patient's symptoms, whether it is there. And the best way to identify is you remove the temporary filling, irrigate and dry with a paper point and observe the canal. If the canal is dry, it means that the calcium hydroxide has worked. Whereas if the canal is not dry, if you see there is some weep, that's why they call it as weeping canal. If you say there is some degree of gentle liquid which is coming up, then it means that you will need another dressing. That's how you decide whether one dressing is enough or two dressings are enough.
Sir, the questions are pouring in. We will take one or two questions more.
Fine, no problem.
Irrigation protocol for open apex and large periapical cases, and the irrigation protocol for retreatment.
It's almost the same. For open apex and large periapical cases, I would personally prefer a sonic activation rather than an ultrasonic activation, because remember, I want to first tell you the difference between ultrasonic and sonic. Ultrasonic is like water shower. Is like water shower. When you bath, you have water shower. You have like how pressurizedly the shower hits you, like that you put on yourself. That is called ultrasonic. Whereas sonic is like washing machine. When you put clothes on the washing machine and on, you saw how it does like that. Okay. So when you have an open apex, I'll prefer something like a washing machine, because I don't want anything to be pushed beyond too much. So sonic is better. Sonic means your endo activator, or what Dr. Ruxana asked, pads. Both are sonic. So though they are preferred in the case of open apex. Whereas in a normal cases, you can either use a sonic or use an ultrasonic. It doesn't make a difference. And for retreatment, the same protocol. Nothing big about it. The same protocol. Only thing is, in the canals where there is a little bit of a lesion, you may have to increase the amount of activation time, and the choice of the sealer has to be calcium silicate or biceramic sealer if it has a lesion in a retreatment case.
Now, which is better, lateral condensation or single cone obturation technique?
Again, depends on the sealer. If it is bioceramic, single cone. If it is zinc oxygenol, lateral condensation.
Then methods to heat hypochlorite.
Intracanal, that's the best. Olden days, they used to actually put hypochlorite in a beaker, heat it, and all that is gone. Now you put the hypochlorite in the pulp chamber, and you can use touch and heat or anything which can heat up, or just take your micro torch. Use it for orthodontic torch. Just take your plastic instrument, heat it, and just touch it into the pulp chamber and heat it. So intracanal heating of hypochlorite is the best.
Then, sir, would you prefer simultaneous irrigation and activation?
Yes. That's how it is. No? When you simultaneously activate it, and then you irrigate, you flush with saline. Sodium hypochlorite has to be activated. No doubts about that.
Sir, whether sonics are useful in hypoactivation or not?
They are useful. Endo activator is sonic. PATS is sonic. They are sonic. See, scientifically, according to literature, ultrasonic is better. If you ask any speaker who has been more into academics and research, they'll say always ultrasonic is better. I don't deny that. But sonic is more user friendly. Because when you have, supposing an upper 7 or a lower 7, and when you have a plastic cannula, it's easy for you to bend and put it like this. Whereas ultrasonic will always have with metal. So when you have a metal, you should be very, very cautious as if the metal doesn't touch the canal wall. If it touches the canal wall, it will break. So ultrasonic is more difficult to use, but it's more effective. Sonic is very, very easy and user friendly.
Sir, to get a good activation, is it necessary for the tip of pads to the apex? Because most of the time, tip of the pads doesn't reach up.
Not necessary. Not necessary. As I told you, sonic, whether it reaches or not, doesn't matter because it tumbles. It's like this. Remember, whenever you talk about sonic, think of washing machine. Is it necessary that the cloth has to be in the forward of the machine or the back of the machine for it to get wetted? Not necessary. When you put the cloth, automatically it tumbles. It's like that. So the moment your pads or your sonic goes inside, it starts tumbling like that. So water energy goes inside.
Sir, is it true that EDTA deactivates the hypo?
Very much true. It does deactivate hypo. There's no doubts about that. That is also one of the reasons why EDTA gels was not used in conjunction with hypochlorite. Very much, yes.
Sir, we will wind up.
I think it was a pleasure because lecture was only 1 hour and the question was 45 minutes. I enjoyed it. This is actually much better, sir.
Yeah.
Rather than for me talking for 2 hours and people getting bored. That's why any webinar I always believe 45 minutes to 1 hour, and then half an hour of questions, so that it keeps everyone at bay, everyone interacts, and it's actually the session is interesting.
Sir, now may I invite our secretary, Dr. Jitin, for the vote of thanks.
On behalf of Team Idea Kodungallur, I would like to thank Dr. Narasimha Bharadwaj sir for enlightening with this commendable talk on minimal invasive endodontics. It was a very informative session, sir.
Thank you so much.
I thank our president, Dr. Shemi Mohammed, our treasurer, Dr. Arjun Prakash, our CD chairman, Dr. Baiju Sia, for the continuous support in conducting the program. I would like to thank all the members of Idea Kodungallur for their participation. I would like to thank our team MedPiper and Danceplice Rona for their continuous support. Last but not the least, I would like to thank all the participants pan-India for attending our webinar. Thank you, one and all. Thank you.
Sir, thank you, sir, once again.
Thank you so much. I'm just typing a thank you there to all of them.
Thank you, sir.
Wonderful Sunday evening.
I'm happy that almost 120 people were there, and
Yeah.
all of them. Generally, it happens. I've been an attender. I've been an attendee to a lot of webinars. It starts with 120 and then it ends with 20 or 30. So I'm happy here. Almost 100 people are there still. So thank you very much for this wonderful opportunity, Dr. Shamim, Baiju, and Dr. Jitin. And
Thank you very much.
thank you,
We
sir.
have what we have learned, we have unlearned, and we have relearned.
Thank you, sir.
What concept we learn now? Like,
Thank you, sir. Looking forward to come and
And,
present that present.
Of course.
okay, sir. Looking forward for that.
Thank you,
After
sir.
once the
Bye-bye.
pandemic is over, and I'm sure that those who have missed this session has missed a lot. Sure of that. That's my
Thank you.
personal opinion on that.
Thank you very much for your words, sir.
Thank you.
Goodbye. Have a great Sunday to all of you.
Thank you, doctor.
Take care, sir. Stay safe.
Stay safe. Thank you.